annual Impact Melanoma Symposium. We are thrilled that you are here, and thank you for taking the time to join us this evening. Special thanks to Sharon Mallory and the Vermont Department of Health for sponsoring tonight's program. I am Amy Mason, the Event Program Manager at Impact Melanoma. We have a terrific panel of speakers tonight. First, you are going to hear from Alan Geller, the Senior Lecturer at the Department of Social and Behavior Sciences, Harvard T.H. Chan School of Public Health, as well as longtime member of Impact Melanoma's Medical Advisory Board. Next, Lacey Adams, melanoma advocate and wife of the Surgeon General, Jerome Adams, will share her personal story of melanoma. Followed by Dr. Caitlin Jay, an assistant professor in dermatology at the University of Vermont Medical Center. In advance to all of them for providing us with a great program. Many of you are already familiar, I'm sure, with Impact Melanoma and our work, so we just wanted to give you a quick overview. Our mission is to reduce the incidence of melanoma and provide support to patients and their caregivers. We offer several education programs, and I'll just go through some of those. They include our support services and our Billy's Buddies program. They both offer support for patients and their caregivers, and we also match patients with a buddy who has been through a similar diagnosis and or treatment. Safe Skin at Work is our education for outdoor workers. Practice Safe Skin is our very popular sunscreen dispenser program seen throughout the United States. No Sun for Babies, reminding parents about the importance of protecting their newborns. Skinny on Skin for those in the hair and beauty profession to learn how to recognize suspicious lesions on their client's skin and talk to them about what they see. And Your Skin is In is our program where we educate teens and young adults about the dangers of tanning and skin cancer prevention. So before we get started, we wanted to just remind you that you're welcome to post any questions that you may have throughout the evening. We've asked that you do that into our chat box on the side there, and presenters will answer them at the end of the session. And now I'm very happy to turn over the presentation to Alan Geller.
Okay, I guess I'm on. Teresa, I just want to make sure everyone's seen my slides.
Yes.
Wonderful. Okay. Well, it's great to be with everybody this evening. Thank you all so much for joining us. Thank you, Amy, for the introductions. And it's been wonderful to be a member of the Medical Advisory Board to Impact Melanoma for this many years. It's just really an amazing organization. And I see in our group tonight, my very close colleague, John Antonishak from the National Council on Skin Cancer, who has worked with Impact Melanoma and many other foundations across the country. So I'm going to talk with you today on really more so on the value of early detection of skin cancer. And I can speak about it as a researcher for more than 30 years, but also as a melanoma survivor myself. And I was been diagnosed twice, once in 1984, a second time in 2007. And the reason that I'm speaking to you tonight is a lot to many of you who may not necessarily be melanoma patients, but those of you who might be first degree family members of melanoma patients because of the extra risk that you have, but what early detection can do to really improve one's ability to look at their skin, to talk with their doctor about skin cancer detection. So that'll be sort of the focus of my presentation. About advancing my slides here. Oops. Sorry, Sorry. Um, Teresa, I'm sorry, the slides just,
I think if you
okay,
click.
there we go. I'm all set. Thank you. So let me just give you just a little review of where we're at tonight. So skin cancer is the most common cancer of all cancers diagnosed in the United States. And in the last year, about 5.4 million skin cancers were diagnosed in 3.3 million people across the United States. Now, fortunately, the large majority of those are basal cells and squamous cell cancers, which can definitely cause quite a bit of morbidity. But the cancer that we're really going to focus on most tonight is melanoma, which is the most commonly fatal type of skin cancer and the most serious one. So we know that more than 100,000 Americans will be diagnosed with melanoma in 2021. And now it's the fifth most common cancer in the United States. I remember starting as a melanoma researcher when we would say it's about the eighth or ninth most common cancer. And we can now say it's the fifth most common cancer faced by men and women in the United States. One thing that we can say about melanoma compared to many other is that we know ways that cancer can be detected early. And when I give talks to medical students or medical residents across the country, one thing that we always say to them is that it's the only visual cancer. It's the only cancer that you can see. And so the screening exam should be ideally and done expertly well by dermatologists is a head to toe, front to back visual examination. Second important point is that 5-year survival has improved from 60% to 90%, stalled since the mid-1990s, but we have seen some strides since then because of the emergence of new treatments for metastatic and advanced melanoma. And there's a number of things that we as public health people and as dermatologists can look to as ways to improve early detection. For the public, we talk about the prompt seeking of care for changing moles, to do a careful monthly skin self-exam to avoid tanning beds. And we have very good evidence that the number of people using tanning beds in the United States has dropped precipitously in the last 10 or 12 years, and covering all parts of the skin exposed to the sun. So those are at least 4 things that the public can do. And for healthcare professionals is really trying to integrate the patient exam, skin exam into a regular exam, and to teach patients how to do skin self-exam. I'm going to mention a number of times the theme of patient activation, or the squeaky wheel gets the oil, the concept of the patient being in the driver's seat when they're at their doctor's and advocating for oneself to make sure that you get a good skin cancer examination as part of your annual visit or a regular visit. So it starts often with awareness, like everything else. And we did a survey, I'm dating myself, but this was back in 1995, and we'd love to repeat it, where we asked people, can you tell me what melanoma is? And we did little focus groups before, and people said, oh, sure, I know just what melanoma is. It's what my wife tells me to be really careful about when I'm cutting chicken. Well, it's not salmonella, or it's something that I take when I go on long distance flights. It's not melatonin. So there was a tremendous confusion about what it is. And as you can see from the slide, only about a third of Americans back in 1995 knew that melanoma was a form of skin cancer. And you can see there's differences by gender and age and education. So this tells us back then, and I think it would tell us now, that the most important thing that organizations like Impact Melanoma can do is just to continue to raise public awareness of what melanoma is, what the warning signs are, and what one can do to detect cancer early. So there's great potential for early detection since it is the only visible cancer. And this is how physicians and dermatopathologists measure melanoma. They do so by the thickness of the tumor when it's removed. And what we aim to do, and why all of the public education zeroes in on this, is the importance of the earliest detection possible. You can see if you look at the red bar over to the left, and even the bar to second to the left, that the earlier that one can find melanoma, the chances of survival, the chances of doing very, very well are extraordinarily high. And since it does present itself on the skin for many people to see, we have a great opportunity to do that. So this is a wonderful line from a surgeon in Queensland who wrote, "Melanoma writes its message in the skin with its own ink and for all of us to see." And we really stress all of us. Again, by it being visible, family members, the public, everybody can play a role in trying to detect this early. We further pinpoint this by showing this graph, which indicates that about a third of melanoma in men, as you can see, the second person from the right is on the back, and about 20% of melanoma in women are on their legs. And often people can't see their back. And so this really brings in two very important partners. One, your partner who you live with, and two, your partner in early detection, your dermatologist or your primary care physician or nurse, just to say, doctor, I have a lot of moles, or my family member was just diagnosed with melanoma. Would you be able to take a look at my back just to see if there's any moles on my back that look a little worrisome to you? So again, just try and remember that one very important statistic, that a third of all melanoma in men is on the back. And you can see quite a few on the backs of women as well. And many of you may know about the ABCD rule. We'll add an E as well. That's ABCDE for evolution or change. But I love this little slide because, and we'll just look at one of them, and you can see if you look at the top left, asymmetry, it's essentially just meaning that it looks different to one side than it does to the other. And if you look from the far left over to the far right, you can see how the mole changes in terms of its difference in shape. And you can see that for A and B and C and D. But the most important rule is if you see a change in your mole that's just different from the way that it was, make sure to bring that to the attention of your doctor, whether that's your dermatologist or a primary care physician who will look at it and hopefully refer you to a dermatologist. So when we compare melanoma to other cancers, there's a good story and a not great story. So for other cancers, and some people might not be aware of this, there's been tremendous progress in reducing the number of deaths for prostate cancer and breast cancer, colon cancer, and cervical cancer. But until fairly recently, we were beginning to see melanoma being a bit stubborn, that the mortality rate was not dropping for melanoma as it was and has been for other cancers. And now very recently, with the advent of new immunotherapy and drugs for melanoma, we're beginning to see a drop there. But the key point to make, I think, here is that more people have mammograms, prostate cancer examinations with PSA, have colonoscopies than they do for melanoma. So that's the cancer for which screening really lags behind other ones. And again, this is one of the reasons why we do talks like this, is to encourage people to screen, to ask their physicians to screen, to yell it from the mountaintops about the importance of screening for skin cancer. We talk about some groups that are at slightly greater risk for more serious melanoma, but we do want to make the point that for people between the ages of 18 to 85 plus, all people are at risk. These are just groups of people who are at higher risk, and that includes middle-aged and older men and older women, persons of lower socioeconomic position, just meaning that when a person of a different social class is diagnosed with a melanoma, they tend to do a little bit worse, often because of later detection. And again, those high-risk anatomic sites, the back in the scalp. And I'm sure if I were to ask you all how many of you have had a full scalp exam, I might find that many people have not. But we get concerned about scalp lesions. But again, the importance of early detection, to ask to make sure that you have someone look at your scalp. And so when we look at deaths from melanoma, about 3/5 of them are in white men 50 years of age and above, and we've identified this as a real important group for targeting. So why do we focus on the back and the scalp? Well, we talked earlier about the back of men, backs of women, that late detected back and scalp lesions are generally thicker. And again, remember from my slide, we really want to, early detection is aims to find it as thin as possible. And Amy mentioned the role of hairdressers and barbers, and impact melanoma has played a great role in terms of educating hairdressers across the United States, because the average person is more likely to see their hairdresser during the year than they are to see their primary care physicians. And hairdressers can be fantastic people to learn, to look, to see what a suspicious mole of the scalp might look like, or the back of the head, and then refer people to dermatologists. And many of my dermatology friends will say that they frequently get referrals from hairdressers. Again, concentrating on the back, you can see here in this gentleman a fairly mole-free back, but for the exception of this one suspicious mole. When we say face it, you can't watch your back for melanoma, but we can. So the importance of knowing your moles, watching for changes, and asking your doctor for a skin check. And it takes a little bit of patient activation, because most often a person doesn't really walk in to the doctor's office with a real mole on his or her shoulder. So, whenever we give this talk, we always want to make sure that both the public's aware of this, and physicians and nurses are aware of this, hairdressers, physical therapists, because we have golden opportunities. Middle-aged and older men make at least 3 to 4 visits per year to a physician or a medical care facility. And our data has shown, unfortunately, that there's a number of missed opportunities, so that if we ask somebody who's been diagnosed with melanoma, did you have a visit during the past year? People will often say yes. And so we want to make sure that those visits to primary care physicians are maximized and utilized to the greatest potential possible to make sure that the skin cancer examination takes place. So we can look at a couple of questions here, and I'll skip this and just move on to the next slide. This is another study that we did where we asked people who discovered your melanoma. And you can see here that the brown bar, that in 2/3 of the cases, women said that they diagnosed melanoma by themselves. In about 2/5 of the time, 42%, men said that they diagnosed melanoma by themselves. So there's a clear gender disparity. But what we found to be most striking is those yellow bars. In 25 instances, the spouse found the melanoma. 23 of those 25 times, it was the woman finding it on her husband. So clearly women are playing a very strong protective role often, and I'm sure there'll be some heads shaking affirmatively to say women buying the sunscreen, but now we see, of course, that women are probably playing a stronger role examining themselves, but also taking on the job of examining their husbands and making sure that their husbands, if there's a suspicious mole, are encouraged to see their doctor. So again, the importance of early detection and skin self-examination. So we look to see, well, how is melanoma currently detected across the population? There's mass free skin cancer screening programs, and the American Academy of Dermatology has done a spectacular job over the years alerting the public to them. But the most common way that we see melanoma being detected is either by what we call opportunistic screening, where it's found by dermatologists or non-dermatologists in about 1/4 of the instances. But again, the key point, which is different from any other cancer, one can't find their own colon cancer, or one can't find their own prostate cancer, but here's a cancer where at about 3/4 of the time, the individual is finding it on themselves. And that's all well and good. It's really important. And hundreds of thousands of melanomas have been diagnosed have been detected by the individual and then confirmed by their doctor. But we really encourage, again, that concept of the squeaky wheel gets the oil, the importance of making sure that you ask your doctor for a back of the body exam. And we've seen here in those many people that where we did a joint study out of California and Massachusetts and Michigan, that when people had their melanomas detected by a physician, 92% of the time, the back of body melanomas were less than 2 millimeters. And you can remember from that red bar that I showed you that's a very, very favorable point of detection if one can find melanoma less than 2 millimeters. So again, the importance of back melanomas and the importance of early detection of back melanomas. Skin self-examination, we have very good data from one large study in Connecticut that for people who did a vigilant, careful skin self-examination, that there's reduced risk of advanced disease compared with people who did not, and a reduced mortality for melanoma, again, for people doing skin self-examinations. So my last couple of slides, just to try and bring this most up to date, is the question of, well, what happened in the last year during the pandemic? And there's a study that we participated on with a number of dermatologists across the country, where we had an opportunity to survey 18 dermatologists about their practice. And we found out that the mean in-person weekly visits for new melanoma patients significantly decreased. You can see from about 5 to less than 1 from March to May of 2020. The number of weekly telemedicine visits increased slightly. In most cases, as you can see, follow-up patients were rescheduled for in-person appointments with a delay of about 11 weeks. And there's definitely a concern about delays of 11 weeks. Lacey will talk more about it far more personally. And I know that Dr. Shea will as well, about the importance now of making sure that for anyone who has not seen their doctor because of a suspect mole, it would be great to be able to do so as appointments are available and offices are doing everything possible to make them be as clean and as accessible as possible. So the second to last slide, we can see here in Italy, which got hit really badly by the pandemic, they had an opportunity to look at cancer diagnoses prior to and after or during the pandemic. And you can see here that cancer diagnoses fell by 45% in 2020 in Italy, compared with the average number recorded in 2018 and 2019, with melanoma and non-melanoma skin cancer representing 57% of all missing diagnoses. So this was a tough time and one that we think we're over the hump with now and can try and fix. So in summation, my last slide is, again, what can we all do to improve early detection? Repeating, carefully examining your skin once per month at a regular time. For areas that you cannot see, ask a friend or a partner or spouse to help. Be a self-advocate. Your doctor will look at your skin if you ask, and there's very good evidence to show that from a number of studies. And make sure to ask for a referral to a dermatologist if you still have concerns. If you have a mole that you know has been changing and you approach your doctor and mention it, the chances that they'll act on it are extraordinarily high. But if you feel that the response is not what you'd like to hear, just be a strong advocate and ask and try and make sure that they refer you to a dermatologist to get a second set of eyes on that. So hopefully this is helpful. And at the end, after we have our two speakers, I look forward to being able to answer any questions that you might have. Thank you very much.
All right, thank you, Alan, so much. Always such excellent information and advice. And we will now hand the presentation over to Lacey Adams.
Hi, can everyone hear me? Good. Okay. Hi, everyone. Yep, I'm Lacey Adams. Like Amy said, my husband was the most recent U.S. Surgeon General, and oh, sorry, that just distracted. And we spent the last 4 years in D.C. and have finally kind of gotten out of Crazy Town and kind of continuing normal life now, but what I'm here tonight to talk about with you guys is my melanoma story. And it started about 10 years ago. I had just had my third child, and it was at just a postpartum appointment with my family practice doctor. And I showed her a mole that I had found on my outer thigh that was not big, but it just looked a little weird. Like I don't have a lot of moles, so it kind of stuck out. And we went ahead and had it taken off at the office, and it turns out it was melanoma, which I was shocked, and which I probably shouldn't have been, because very fair skin, red hair. I used tanning beds all the time from starting 16 to probably late 20s. So I really should not have been shocked, but I was. So we had it surgically removed, you know, the wider excision and clean margins, and just kind of went on with life. You know, I did all the right things. We saw dermatologists regularly, avoided the sun, was better about sunscreen, and just kind of went on normal, you know, living my normal life. And then fast forward about 9 years later, and I've not thought about it forever. We had just moved to DC, and my husband was just appointed into his position. And I noticed a few lumps on my groin on the same side that I had the mole removed. I honestly didn't even hardly connect the dots since it had been so long, until finally a friend that her husband's an oncologist, I just mentioned it to her. And she's like, oh yeah, you need to go right away. So I did, and we found out pretty quickly that, again, it was melanoma, and it was in fact, like after they did genetic testing, the same melanoma from 9 years ago. So not sure why it took 9 years to spread, but it had. So then again, had surgery to remove all my lymph nodes on that side, and started a year of immunotherapy, specifically Opdivo. And it was a pretty easy year. I had hardly any side effects at all, just like rashy skin, dry mouth, some fatigue, but not bad at all. I used to joke that I was like a immunotherapy superstar. I was like, this is this is so easy. So then after my year of that, I had clear PET scans that whole year. I thought again, I was like, okay, I'm in the clear again. So for 14 months, I had clear scans. Then unfortunately, in July of 2020, so past year, I had a PET scan, and we found a spot that had come back. So once again, I had surgery to remove the spot. This time it was on my back, and started another year of immunotherapy, this time doing the combo treatments of Yervoy and Opdivo, which was definitely not as easy as Opdivo was. So I've definitely been having some struggles with that, but I'm hanging in there, and I'm about halfway through. So let's see. Oh, and I have a PET scan on Monday. My first PET scan since I've started treatment on Monday. So hopefully we'll get great news then. But this brings me to my real message that I was here for tonight. I had a clear scan in January of 2020. And then they found my new melanoma in July of 2020. As a melanoma survivor ×2, I should not have gone 7 months between my scans, but it was in the middle of COVID. We were so good about quarantining, and I pretty much had not left the house. The kids haven't left the house, and I just really did not want to take the risk for what I thought would just be a routine checkup. You know, that I just didn't think it was going to be worth the risk. So it really made me realize that just how important it is to stay on top of your screenings and routine appointments, even during a pandemic. Our families, they really need us, and they need us healthy. So we really can't make excuses or feel bad about putting ourselves, you know, putting our health as a priority, and even during a pandemic. And so, so book that appointment. If you've been putting it off, call tomorrow morning and get the appointment booked, because there's just no excuse. And that's pretty much what I have. So thank you for letting me tell my story, and I hope it inspires someone to, to book that appointment and get things moving, and hopefully everybody can stay healthy. Thanks.
Thank you so much, Lacey. Thank you for sharing your story, and your message is so important. We're grateful that you were willing to share it with all of us.
You.
Dr. Caitlin Shea will be presenting. So, floor is yours, Caitlin.
All right. So thank you again, Lacey, for sharing your story. I think it's so important, so many aspects of your story, and I'd like to highlight a few actually from my own perspective. One of which is that the immunotherapy for many people is pretty tolerable. And prior to about 10 years ago, the therapies were really intolerable for most. And so there have been great advances, which you're highlighting right now. And then also, yes, we do want our patients to come in and see us. You know, I'll get into this in a little bit, but we are ready to see patients, and I'll reiterate, don't put it off. Okay, so let me get back to the screen share and there we are. Okay. So again, I'm Dr. Caitlin Shea. I am a recent graduate from the University of Vermont Medical Center, where I did my residency and also my intern year. And I was hired, you know, I am so thankful to have been hired on during the pandemic, which I think is a testament to the University of Vermont. And so I think we should start with, where does melanoma come from? So it comes from melanocytes, and those are the cells that produce pigment in our bodies. And they are derived from an embryologic structure called the neural crest. And they migrate into the skin and into the hair follicles as embryos develop. And they also travel to the eye and to the inner ear, the brain, and the spinal cord, and sometimes to other organs as well. So any organ that contains melanocytes actually can be a site where melanomas can develop. And it is, again, the 5th most common type of cancer in men and women, and the incidence does increase with age. So there are a lot of different types of melanoma, and I thought that the easiest for me is learning by pictures. So the first ones we'll look at superficial spreading melanoma, and this is the most common type of melanoma. But there's also nodular melanomas, which are these ones here, which are sort of more bumps. Then we have lentigo maligna melanoma. These are melanomas that often are flat and on sun-damaged skin. And then there are acral lentiginous melanomas, and those ones are on the palms and soles. And that variety is more common in people who have darker skin types. And then there are other less common variants as well, including subungual melanoma, which is a melanoma of the nail unit. And then amelanotic melanomas are another type. Those are ones that aren't pigmented, so they might not look dark. And as you can see, that picture is just a little red bump. Uveal melanomas, so you can get melanomas of the eye because those melanocytes make up or enter the uveal tract, which make up the iris and the muscles of the eye and the choroid at the back of the eye that senses the vision. You can also get melanomas in the mucosal skin, so in the mouth and the skin of the genitalia and the anus as well. So we did look at this kind of schematic earlier about what to look out for, and the ABCDEs, you know, we did talk about it, but I think it's the most important thing that will help you identify a melanoma. So we'll just go over it again. So asymmetry, if you cut something in half, it doesn't look the same on both sides. Irregular borders, you know, they're maybe jaggedy, or perhaps some of it appears nice and crisp, but then maybe you have a little part growing off. That's not normal. Multiple colors or jet black color we don't like. Diameter greater than a pencil eraser, and then E for evolving. So again, that is the most important thing. Things that change over time are not normal. But what I also like a lot is the ugly duckling sign. And I think that this is really easy for people to conceptually remember rather than so many letters. So the idea here is just, I like to think of it that you have a bunch of spots on your skin and they look somewhat similar to one another. Maybe they look sort of like a family together. But if there's something that sticks out, something you might consider an ugly duckling, that is something that you should bring to the attention of your doctor, because the ugly duckling is a great mnemonic that I actually have a colleague who has a PowerPoint of skin lesions that she biopsied that were just ugly ducklings. And sometimes they didn't even look as worrisome as some of the photos that we saw earlier. But because they were the ugly duckling on the person, they were biopsied, and many of them turned out to be melanomas. And then how do you monitor for melanoma? So we talked about having a doctor monitor your skin, and that is very important. One challenge in getting into a dermatology office in some locations is that a skin screening exam, sort of a prevention exam, is not a covered service by insurance. The US Preventative Services Task Force doesn't consider it necessary. And so you pretty much have to have a reason to come into a dermatologist. So if that's a changing mole or something like that, that is a reason that you can be seen. But often, if your insurance requires a referral, you may not be able to get in to see a dermatologist without a reason. And that's where primary care comes in. So if you see something that you're worried about, bring it up to your primary care doc. They can always get you hooked up with a dermatologist if needed. And then we do tell our patients to monitor their own skin. I like to say only about once a month. I think if you're looking at your skin more frequently than that, it's more difficult to notice changes, kind of like watching a child grow up. Like, I don't see my children changing, but when I see my parents after a long period of time, they think my children look so much bigger. So, doing your own exam is good, but you do have to space it out so you can see those changes. And then seeing a dermatologist at the interval that they recommend for you. So depending on if you've had a skin cancer before, if you've only had precancers, if you've had a melanoma or an invasive melanoma, the frequency at which your doctor might want to see you back will change. And what they recommend, you should feel comfortable with, especially if that's your dermatologist. So just for reference, in our office, we do generally see patients who have had melanoma in situ every 6 months for 2 years. And if they didn't have anything new during that time frame, we might go back to once yearly appointments. But for patients who have invasive melanomas, we tend to see them about 3 to 4 times per year for the first 2 years and then space it out. And then in a more general sense, we also want patients to tell us if they develop fevers, chills, night sweats, unexplained weight loss, which occasionally can be associated with metastatic disease. And so just some ideas. It is hard to see your back, of course, and so having your doctor take a look is good, but here are some other ideas. So using a full-length mirror or a handheld mirror can help you check spaces that are hard to see. All right, so and monitoring for melanoma during a pandemic. So we're still seeing patients in our clinic, and we have been throughout the pandemic. We're one of the few offices that has consistently seen patients, and you probably would like to know, how are we keeping people safe? Well, we do have a lot of measures in place. Everyone who comes into the building gets screened with a temperature check and a symptom screening check. And our appointments are now only the patient themselves, unless there's a reason that they need to have someone accompany them, such as if they are a child or have special needs. And then, another good thing about our institution and most other institutions in the United States at this point is that the people working there, doctors and medical assistants, and really everyone are vaccinated. So, and everyone's wearing masks. So it is quite a safe environment. So yeah, again, we don't recommend canceling your skin check, especially if you have a history of melanoma. If you're uncomfortable being seen in person, you could do a Zoom visit. That's something that we sometimes do, but of course it's not possible to do a thorough skin check that way. Sometimes, a photo can be okay for a while, but ideally we do want to see people in person. And what can we do for prevention? At least SPF 30 sunscreen. Pretty much all of them now are broad spectrum. Applying it daily, at least to your face and neck, or other sun-exposed areas. When you're outdoors, especially for long periods of time, you do need to reapply after 2 hours. And then another good option is sun protective clothing. And I just listed a few places where you can either find them or brands that make sun protective clothing, and hats. Also, being in the shade is helpful. So in summary, melanoma is, we know there's a relation to your exposure to UV radiation, especially we think in early years, but also there is a genetic component. So earlier we mentioned if you have a first-degree relative who has a history of melanoma, that you should also be screened. And then some important things to keep in mind. So in adults, most melanomas show up as a flat, dark spot that will change over time. They can be associated with moles, but they are not always. Sometimes it's just a new spot. And perform your self skin checks using the ABCDE rules and the ugly duckling rules. See a dermatologist if you have risk factors, and protect yourself with sunscreen and sun avoidance. And we talked a little bit about some of the resources, but just to reiterate, Impact Melanoma does have support groups for melanoma patients and their families. They have both telephone and in-person support groups, though not currently because of the pandemic. And then the Billy's Buddies program, which matches up patients based on stage or treatment with other patients with a similar diagnosis. And you can find their resources at their website. That's all I have.
Yeah, welcome. Great. Okay, so for tonight, you don't need to do anything. Okay, got it. I even used this one, if you want to take a picture of it. Okay, that's the bare mineral blemish therapy.
All right. So thank you so much, Caitlin. Such great information, and such a good reminder too, to make sure that everyone is checking in with their dermatologist even during these difficult times. If you have anything that is suspicious and need to have it taken a look at, so don't delay doing that. Thanks to all of our panelists. It was really great information, and we appreciate your time in speaking with everyone tonight. And now we'd love to open it up to anyone who may have questions that you would like to put into our chat. All you have to do is go over to the chat on the right-hand side and just type in your question there, and we'll make sure that they get answered for you. So the first one that's come up is, are there sites that I can point my partner for? What to look for in a skin check on me?
Yeah. Am I muted, or do I?
Nope, you're not. Caitlin,
Okay.
if you want to answer that, that would be great.
Yeah, so I really think that the easiest thing to tell someone is to look for an ugly duckling, something that stands out from the rest of the spots. I think it's the easiest to remember, and it's also been shown to be a highly effective way to find melanomas.
Great. Thank you. Next one is, can you send the clothing lines? Again, the screen was not up long enough. I also wondered
Oh.
if lumbar wasn't on the list.
Yeah, Mott 50, I like. Cabana Life, I guess, was founded by someone who had a melanoma. Wallaroo makes good hats. And then the Sierra one is just Sierra Trading Post. So there are a lot of brands that what you want to look for is they say UPF, which is like the UV protection factor. And as long as it says that, I trust it. And you can find things that are inexpensive at Sierra Trading Post, whereas some of these I find can be pricey, and I only buy them if they're on sale.
Thank you. Is there specific information for Indigenous populations?
I guess I might need to know a little bit more information. Like what types of populations?
Okay, we'll come back to that if Karen, you wanted to be able to enter in some more information about that so that she can answer your question. And the next one is if there are any hats that are okay, or should I look for SPF hats?
So the best hat that you can get is something that has a broad brim and goes all the way around the front and the back, so that you're shading not only your face, but your shoulders and your neck. And some hats do have a UPF rating. It's hard for me to say for sure that your hat needs to say that. I mean, I think if it shades you and you feel cooler when you're wearing it, I'm sure it's blocking a significant amount of sunlight. That being said, if you find one that does have that UPF factor listed, then it's just another assurance that it really is blocking those UV rays.
Okay, and then the next one is, how are non-dermatologists trained about skin cancer? My family physician pretty much says she is ignorant and is happy that I see a dermatologist regularly.
Yeah, so I mean, it's very limited. If you think about all of the many things that physicians need to learn about, in my medical school, I think our derm education was about 3 days long. So there's not a lot, but they do see a lot of patients. So just over time, they are able to develop, some sense of what things might look okay or not okay. And if they don't know, then they'll just send you on to a dermatologist. And then that's a great reason to see a dermatologist.
Great, that makes sense. The next one is from Kristen, and it says, thank you to all the speakers. And 2 questions. One, Dr. Geller mentioned about primary care docs looking for spots. Are they being given training in their residency or fellowship years, which is a little covered just now? And also, Dr. Shea said a governing body said that they didn't consider dermatology as a doc people could see on their own without a referral. Is there a way we can advocate for change?
I can go back to the first question. I think Dr. Shea totally nailed it. There's very little education at all during medical school. There's very little education during residency. It's probably less. But there is evidence. We've participated in a number of studies that when primary care physicians do receive training, that their ability to be able to not diagnose, but at least triage definitely improves. So there was a study done out of the University of Pittsburgh Medical Center where about a 90-minute PowerPoint was given to primary care physicians and encouraging them to screen. And the good thing about that is that there was a reminder on their electronic medical record about making sure that they screened the body. About 19% of primary care physicians did so. And the good thing about primary care physicians is that when they screen, they often have hundreds, if not thousands of patients. So the average doctor at University of Pittsburgh had about 1,000 patients. And so if you can get one doctor to screen 1,000 people, multiply that many times over, and they have an ability to readily refer people to dermatologists, I think that's a great, sort of a win-win situation. So we're all all we're really talking about is sort of triaging. That is not making a diagnosis, but saying, you know, something on your skin just doesn't quite look right. I'm a little bit out of my wheelhouse here, and I'm going to refer you to a skin expert who will be able to help you out. So again, the importance that I mentioned, I'm sure Dr. Shea and Lacey would agree, is for patients to be their best advocate and to advocate for a good, careful skin exam, most likely to be done by a dermatologist.
Yeah, I agree. And then along with that, you know, like I was saying before, some primary care do take a special interest in that too. And so they may seek out additional training. And at UVM, we have advanced dermatology for the primary care conference that we have held in the past, and hopefully it will happen. I don't think it happened this past year just because of the pandemic, but the plan would be, I think, for it to happen again. So it's a conference where we do teach primary care docs about what to look out for, biopsy techniques, that kind of thing. And then I did see the clarification on Indigenous tribes. So it says, people in Montana are from various native tribes. So, you know, perhaps the question is regarding skin color, because many people who are Native Americans do have darker skin. And so in people who have fair skin, there's a greater risk for melanoma, but that doesn't go away with pigmented skin. So same things apply. Recommending sun protection for all people is currently the recommendation, although in one of the, I think it was the JAD, one of the journals from February I was just looking at, was talking about the recommendations for sunscreen in people of African American descent and whether that's an appropriate recommendation. So, you know, there's more research that needs to be done, but currently the recommendation is for sun protection for all people.
Okay, thank you. Another question in from Maureen. She wants to know, as summer is coming, she says, I almost dread it because I feel I have to always cover up my legs, arms, and of course face at all times. Is there any amount of sun that is considered safe? It is hard to keep my face out of the sun while riding my bike. Any suggestions?
Yeah, that's a hard one because, I mean, I don't advocate for only going to the beach when it's winter time, as you saw from my photo, but outdoor activities with sunscreen and sun protective clothing. So I know it's hard with biking to be able to wear a hat, but sometimes you can get a visor for your helmet. And then some of the sun protective clothing, or a lot of it actually, is made with athletic materials so that it's moisture wicking, and some say it's cooling. I don't exactly know about the mechanism of that, but I like sun protective clothing so you don't have to remember to reapply your sunscreen or worry about your children sliming it off of you.
If I could just add, John and I go way back, John Antonishak and I go way back, where there used to be a number of people who took the very strong position that the sun should be completely avoided at all hours during the summer. And our exercise friends at the CDC gave us a bit of a hard time on that one. So we've tried for a long time to strike a middle ground where we do encourage people to be outside, but that one can be outside during the summer, but to be outside wisely, and just sort of think of that thing, that any bit of the sun, the skin that's exposed to the sun is a potential trouble spot that should be covered. And we would say, choose your cover. If shade is the thing that works best for you, that's great. If sunscreen, like Dr. Shea is saying, with SPF of 30 is your best tool, that's great too. But it's to really strike that middle ground between feeling comfortable biking, swimming, playing tennis, going for a walk, but at the same time using as much sun protection as you possibly can.
Great, thank you. John asks, technical question, what is the right way to remove a suspicious lesion? Slice it off or do a punch biopsy?
Yeah, So that one's a little bit tougher because there's not just one answer, but in general, it's best to remove the entire thing if you can, because if you do a punch, I mean, if you can remove the whole thing with a punch biopsy, then that would be a good way to go because it gives you good depth. But the challenge is if it's a broad lesion and you only take a portion of it, it may give you an incorrect result. So you really need the entire thing to be able to make a determination.
Thank you. Next question is from Maggie. This is regarding people that have non-skin melanomas such as acral or ocular melanomas. Do you know if they are at higher risk of developing skin melanoma?
Yes, they are. I would not call myself a melanoma expert, but what I can say is that generally people with acral and ocular melanomas, often they have associated genetic syndromes. And so they would have a higher risk at developing skin melanomas. And also someone who has had a melanoma is at an increased risk for developing another melanoma.
This is from Afsan, is Blu-ray screens exposure, if Blu-ray screens exposure could cause any risks for melanoma or other skin cancers?
Yeah, so I think this question is about blue light that comes from screens. So we don't think that blue light does cause any risk for melanoma or other skin cancers, but I do think one important note, unrelated to skin cancer, is that people who have certain conditions like melasma, which is a common condition where people develop pigmentation, just something sort of, I think is sort of neat to know is that the UV bulbs that are in most places do impact melasma development. And so if you are someone who has that pigmentation that you're trying to get rid of, you need to wear a sunscreen that is tinted. It contains iron oxide and that blocks visible light. It's just interesting.
If I could just add a quick little point to what Dr. Shea, and I was delighted to hear her talking about the practice at UVM, where when people are diagnosed with melanoma, that they really keep an eye on them, making sure that they visit, I think, like 4 times a year for the first couple of years. So that the main risk factor for melanoma, quite honestly, is a personal history of melanoma. And the second why I mentioned it in the beginning was a first degree family member with melanoma. And probably the third are people who make lots of moles or a number of atypical moles. So those are the 3 things to keep in mind. And I'll just tell you a very quick story. So when I was diagnosed with melanoma and first time in 1984, after about 10 years, I was seeing my doctor every 6 months. And he said, you know, you're doing really well. I think you can come back and see me once a year. And I called my wife and I told her, and she said, basically over my dead body. You know, the main thing here is you've got to be able to tell your doctor you're at risk and the importance of making sure that you keep up those every 6-month visits. And it was great advice because a number of years later, I was diagnosed with the second melanoma, and I am very concerned as to what would have happened if I was put in a position of having to go every year. So for any of you in our audience who have been diagnosed with melanoma, again, just back to my silly line about being a squeaky wheel, and I hope that Dr. Shea would agree with this, about the importance of just making sure that you have at least 2 visits a year for many years after the diagnosis, because it's hard, and many of you probably know that, to feel like you're doing a great job looking at your skin. You know, you can look, but sometimes there's subtle changes that we can't pick up on our own. We're not trained as dermatologists, but our dermatologists can pick up those subtle changes. The flagrant changes we do fine with. And so that's why I would strongly advocate, and I'm sure people would agree, about making sure that you have at least a couple of visits a year for many years after your diagnosis.
Great. Thank you. Any other questions? All right. Well, thanks everybody for all of your great questions and for joining us tonight. We hope that you will join us at our next event, which is Let's Get Glowing on Thursday, April 8th. It will be really fun to see you all there. You can find more information about that event and other events coming up, as well as all of our programs and support groups as well. If anyone needs any further information, please don't hesitate to reach out to us. Our website is impactmelanoma.org. And we're super grateful to you, Alan, and Caitlin, for your information this evening. And Lacey, thank you so much for being willing to share your very personal story of melanoma. We're all rooting for you and do the very best. And we know you're gonna just, get through this in the way that you have. And we're thinking of you. And everyone, thank you again so much for being here. It was great to have you all.